Okay, I think we have everybody, David.
Yes, sir. That's a quorum.
Good afternoon. Today is September 8th, 2021, and it is 1:03 p.m. As a quorum of the committee is in attendance, I'd like to call to order the meeting of the Central Health Strategic Planning Committee. As allowed by Section 7.5 of the bylaws, the chair will be automatically appointed as a temporary member of the committee to achieve an in-person quorum. Per the communication that was sent by our board liaison, Brianna, yesterday, we have a hard stop at 3 p.m. today. Therefore, I will be managing time for presentations and discussion to ensure that we meet our time commitment. Also, some of our committee members are participating by video conference, so the staff will be managing video and audio feeds of all participants closely to make sure we have a legally compliant meeting at all times. At this time, I'd like to recognize Mike Wiesman to outline some of the video and audio technical issues associated with our first hybrid meeting. Mike?
Yes, thank you, Dr. Bell. Thank you for joining us this afternoon. So as noted, we will be actively managing the technology here for the meeting to ensure that individuals can be seen and heard and the conversation can be appropriately interactive. Also, we will ask your patience as we transition not only between agenda items, but also potentially between speakers and presenters and agenda items, especially as the conversation ensues, so again, that we can ensure that people are seen and heard, that the conversation is interactive. Given different technology platforms that people are using, and also just general technology issues that you have with internet or web bandwidth and Wi-Fi, we're making sure that we can have as productive a meeting as possible, and we thank you for your patience.
Thank you, Mr. Eastman. I'd now like to go on to public communication. Members of the public who wish to make comments during the public communication portion of the meeting must have registered with Central Health via the online form or by telephone no later than 11:30 a.m. today. Yvonne, did anyone register to make comments?
No, Mr. Chair, we have no one signed up to make public comments.
Thank you, Yvonne. We will now proceed to the committee agenda. Agenda item number 1, review and approve the minutes of the August 4th, 2021 meeting of the Strategic Planning Committee. May I have a motion, please?
Yeah, I move that, can you hear me? I move that we accept the meeting minutes from September the 4th, 2021.
Thank you. And a second for Manager Valadez? Thank you. I have a motion by Manager Brinson. I have a second by Manager Valadez. All in favor?
Aye.
Any opposed? Any abstaining? Motion passes.
Dr. Bell, I'm sorry.
Yeah.
Council, I just wanted to check the motion that was verbalized, I believe, was September 4th.
The motion that was verbalized was September 4th instead of August?
Yes.
Okay. We need to correct the motion. Manager Brinson,
I apologize. Yes, I move that we accept the meeting minutes from August 4th, 2021.
thank you very much, Manager Brinson. Manager Valadez, you second?
I second it.
Thank you very much. All right, we have a motion and a second. Any discussion? All in favor?
Aye.
Any opposed? Any abstaining? Motion carries. Thank you. Thanks for catching that. All right, agenda item number 2. Receive an update from the University of Texas at Austin Yale Medical School on Central Health's financial investment and how that funding has been contributed to the fiscal year 2021 outcomes supporting Central Health's mission of serving indigent residents of Travis County. Presenting, I have Dr. Clay Johnson, who is now the Special Assistant to the President and Provost. Thank you, Dr. Johnson, for being here and providing this information to us. We surely appreciate it. So I'll turn the floor over to you.
Thank you, Dr. Bell. It's a pleasure to be back with you all. And although I am no longer the dean, and this will probably be the last presentation that I make to you regarding the medical school, we thought that it made the most sense for me, having more knowledge about what happened last year, to be the one to present today. So next slide, please. So we've shown you numbers like this before. In every year, the percentage of our budget that is derived from funding from central health decreases. And so we're down to about 16% of our expenditures being covered by central health dollars, or dollars that flow through the central health this year. Next, please. And the distribution of those is as follows. Now, first, let me explain. It's a $35 million annual payment that we receive from you all. But you remember in the early years, those payments came when we were a tiny operation. And so we banked some of those dollars. And so some of those banked dollars, most of them have been spent, but there's still some left. And so this year's budget exceeds the 35 because we're pulling down some of those dollars that had been banked from earlier years. And you can see the overall distribution here, the mostly clinical services in population health and health ecosystem. There's small payments to the Design Institute and the Value Institute, and for health equity. Next. So, the reason I'm back here is, I remember I presented what we did last year and also what our planned budget was for this coming year. But at that time, we didn't have a complete year's budget for this past fiscal year. And it's not quite complete yet either. We don't have all the numbers in yet, but this is as close as it's going to get as we clean up the budget for by the end of this month. So now you can see this time last year what we had estimated the budgetary expenditures would be by different clinical departments and what they actually are. And you can see there's some areas in variance where we ended up spending more, in particular for women's health, for internal medicine, a little bit more too for the Value Institute and the Design Institute. Some of this relates to changes that occurred due to COVID. And as you might guess, there was a lot of additional pressure that was put on internal medicine, for example, during this year. And all in all, I think pretty well aligned with what we anticipated spending the money on. Next, please. So then this is another question you all asked. Well, when compared to what we actually spent in this last year, what are we projected to spend in this coming year? How are things changing? And you can see that we are changing some allocations to some extent. Women's health is going to go down a bit. Internal medicine is going to go up, more and more services in that area, particularly in specialty areas, GI as an example. Pediatrics up a tiny bit. Diagnostic medicine, we have some support from external sources, so that's allowed us to take that off. And then you can see decrease in medical education for the health ecosystem, some increase in health equity, and then decreases for the Value Institute and the Design Institute. Next, please. So you all have asked some questions, and Commissioner Valadez, I just received your detailed questions by email, and all very good questions, none of which I'm prepared to respond to today. So just to be clear, they're good questions, but they're I've got to go back to the accountants and we got to look at all of that and into the clinical groups to see to answer your questions. But we'll get that back to you. But what I do have today is what you see here. And you can see that of the total patients that we have seen, this is in our UT Health Austin clinics. This is only a microcosm of all the things that we're doing, but in one place that we see clinics, that about 34% of our patients are covered by MAP, Medicaid, and Medicare. I don't have the breakdown right now for percentages in those groups, but again, we'll get that to you all. And in terms of total patient visits, it's a similar percentage. So it continues to make up a large percentage of our total patients in our own clinics. And then you all have asked some great questions about the residents. And actually, we're making wonderful progress in the residencies, and I'd like to accelerate that. Well, I won't be the one, but encourage acceleration for the next leaders. We have 346 residents, quite a bit more, and I'll show you that in a subsequent slide than we'd had previously. And they'll provide over 700,000 hours of care to patients at 75 clinics and hospitals. Most of that care is in facilities that are predominantly serving the safety net, but not exclusively. And so you can see, 500,000 hours. So really the majority are in these facilities, all of which have, a mandate to serve the MAP population and others who are in need. Next. So, I think just in terms of what we've been able to do in the residencies and fellowships, it's pretty remarkable. In the time that I was dean, we increased from around 250 up to 350 residents, so quite a big increase. But we've just added 21 new programs, and they're in wonderful areas that the community needs. Some of them are fellowships, some of them are residency programs, but you can see here a few of them. Addiction medicine is a great example. We desperately need that. We need addiction specialists in our community, and now we have the potential to train more of them and keep them here. And so, good example. So we actually almost doubled our number of residency programs this year in terms of the proposals that have been through and approved and increasing financial support for those programs. And that will, over the next few years, as we fill those programs up, that'll get us up to 462 positions. So quite a bit of increase. And again, this is the most proximate pipeline for specialists, and most of their training are in the facilities in which the most needy are receiving care. Next, please. So future opportunities. We have some wonderfully successful clinical programs. We need to figure out how we scale those and add more. I think we've had a bunch of different pilot programs that have been extremely successful in showing how when we work together, we can actually lower the costs, increase the experience, increase access, all at the same time, and improve outcomes. So we need to be thinking about how we do those things in partnership. We do need more DelMed clinicians in safety net environments, where we can be helpful, we want to be. And so we'd like to explore with community care, expanding residency programs to actually site them predominantly, so primarily at a community care site, to work with them on whether that's feasible for them to become not to go through Seton in order to place them there, but actually have the ability for them to sponsor their own residency programs in collaboration with us as one way to do that. And then also to work with them on placing our specialists in those facilities too, by having them have both a role in the school and a role in their predominant clinical role in community care. And we have a number already that we've brought in that way, and that model seems to be working quite well. The public health issues, we need more programs that get upstream, and we need to think collaboratively with you all about how we can do that. There are opportunities for us to create a healthier environment and to lower costs if we can get upstream from things. We've had a few start-stops in that area, but not projects that are getting accelerated ongoing support with accountable outcomes. And then we need to continue to work on COVID. I wish that weren't true, but we've had a very successful program with community care for the homeless, which we've told you about before, and that's a model. We need more of that. We have other vaccination programs that have been moderately successful out in the communities that need them the most, and that's going to require continuing attention. The inequities in our community are, I would say, no better or worse really than when I started in my role 7.5 years ago. COVID has really pushed us way back, and we have a long way to go. So I think this is one area where we seem to be really aligned right now. And Joel Mullen's work, and now us, moving to a point where we're really sharing her as a resource and aligning around community goals, I think is going to be quite helpful, and hopefully making some real progress over the next few years. And then I would say the other way to think of the medical school is a multiplicative investment. A good example is the colon cancer screening program that we did with community care, which dramatically increased appropriate colon cancer screening in the community care population, in part from a mailed stool test. And now we're above national averages, whereas we were about half the national average before that program. That was largely paid for, not, we paid for some of it through the med school, you all paid for some of it through community care support, but a lot of that was paid for by CPRIT, and a very large grant that was received to support that. That's a great way to use the med school in terms of leveraging additional access to support. And then through philanthropy too, we've been able to do that, to create additional resources, for example, for the homeless, where we got several large gifts that then immediately went into vaccination and testing programs for the homeless. And we're just in, I think there are many, many additional opportunities to do that kind of work, and we ought to be looking for those multiplicative areas. All right, next slide. Okay, and then just a couple slides on support for Central Health's mission. Next slide. Oh, I guess that's it. I thought we had one more, but this is back to the beginning. Yeah, I must have gotten taken out, but that's okay. That, I believe, is it for my presentation. I'm happy to take questions as you all will allow.
Thank you very much, Dr. Johnston. I really appreciate the information. And I will now open it up for questions. First, before I recognize you, Manager Valdez, I want to thank you for providing us with the detailed questions that you have. As Dr. Johnston stated, he will work at getting that information back to you. Hopefully it can be shared with all of the rest of the board, because they were good questions. And before I recognize you, I'd like to ask Dr. Johnston, I know you've probably defined these before, but the programs listed as Health Ecosystem, Value Institute, and Design Institute, what do those programs do?
Yeah, so Health Ecosystem is run by Minnie Callan, And the Factor Health is an example of a program that is under that umbrella. Again, it receives some support from you, but it's a great example of multiplicative support. They also get support from the Physical Health Foundation and from the Michael Susan Dell Foundation, as well as others. And that's the group that did the loneliness work, for example, in partnership with Meals on Wheels. They have another food intervention that's being assessed right now. They work with payers in mostly Medicaid, but also with some of you all to help to prioritize interventions that exist outside of clinics and hospitals. And that loneliness intervention is a great example of how much can be done in that space and how cost effective it can be. The impact on anxiety and depression was dramatic on a very inexpensive intervention. The Design Institute is involved in a whole host of projects, ones that you all request and ones that are requested by the community. So I'll give you an example. Is early in the pandemic, the city was concerned about outbreaks in nursing homes. And so the Design Institute, again, we got some philanthropy for this, but also used some support through the dollars that come from the community to redesign nursing homes to make them safer. And so they had a whole host of recommendations, and some of them implemented, not all of them, in order to make them safer for people, specifically at that point for COVID. And they worked on many other projects in the community, creating new opportunities for health in subsidized housing areas, that kind of thing as well. And then the Value Institute is one we don't talk to you all very much about, but they have done a lot of the work around what our goals of care should be. So they do work around, what is it that our patients are really looking for? What constitutes good outcomes? And so they'll go and meet with groups in the community when we create new models of care to help to define those goalposts by having a series of meetings with people who suffer from whatever condition it is that they're studying. So that's one. They also create a kind of, through teaching, practicing docs, and residents and medical students, they teach about the fundamentals of working on caring about the outcomes or the health of a patient and really focusing on achieving that health and outcomes. And so they end up consulting on a number of different projects as well.
Thank you very much. I appreciate that. Manager Valadez? You need to unmute Manager Valadez. And Manager Musaitis, you'll be next.
Thank you, Dr. Johnson.
Manager Valadez, go ahead.
Okay, thank you. And the last time you spoke to us and presented, I already had questions, the same questions asked, and I realized that I had not sent them. They were still sitting in my draft. So I apologize. I apologize so much for that. Anyway, one of the things that I really would like to talk to you about or ask you to think about, you're going to be here with the UT system, I'm assuming, correct?
I am not, I'm not saying yet what I'm doing next.
Okay, that's fine. I appreciate that. But I would like for you to consider and have whoever follows you to consider, at least your leadership team there at the medical school, as to whether or not they would consider being a site for doing expanded research and development of vaccines and research on the mutated strains of the COVID, so that we could have at least an opportunity for testing here in Texas and in the development of possible vaccines here in Texas, not at Duke University or New York or somewhere, but here. So that's something I really would like for you to consider, because we're pushing for that. We've even developed a petition for that, but just so you can keep that in your basket of to-dos and see whether or not we can rally some support from the University of Texas system for that.
What a wonderful question, Manager Valadez. I thank you for that. I agree completely. So we actually sought additional support from the legislature for exactly what you just described. We wrote a proposal because we have a lot of the expertise already at the university, right? The original shape of the virus, the key piece that was used for all the vaccine development, that was all work done at UT Austin. And so we think it's going to be really important not just to follow for whatever comes next and be able to do that work very, very rapidly. And I agree with you, testing is the other piece that we should be able to do well. That was not funded by the legislature, but I agree with you, it is that is worth continuing to advocate for, and I will definitely pass that on.
Please, I appreciate that, because we saw that there was such a gap in the provision of services and the targeting of our below 200%, our targeted MAP population. And we can't afford for the city to decide that they are or not going to do something, or how long it will take them to figure out what they need to do. So since we've invested so heavily in the University of Texas Medical School and in your experts, your medical experts, and also in the think tank that exists within your confines, I think that it would be perfect for us to use you to help address those huge gaps that exist, and not only for what we're dealing with now, but for future purposes. Thank you. That's it.
Thank you very much. I appreciate it. Dr. Johnson, did you have any follow-up to that?
No, I hear you. I applaud the question.
Thank you. Manager Musaki.
Thank you, Chair. Appreciate it. Thank you, Dr. Johnson, for coming for the presentation. Thank you for your service for our community, and best wishes in your future endeavors. I have a quick question, and it's been asked several times from the community. I just want you probably to elaborate to answer that question in a minute or less. Your process of selecting medical students. I think there has been a question in terms of diversity of your students. Are you by law allowed to select students based on their race, ethnicity? So if you can just touch base on that, just to the public, and clarify how your selection process is and what you are mandated by law, and how can you select it? Thank you.
Yes, so we are not allowed to consider race as a criterion at all in selection of medical students, and there's a lot of scrutiny on us. And because of the lawsuits that have involved UT that have gone all the way up the court system, and so we are allowed to use things like difficulties overcoming things in life. So that can include a whole variety of things: achieving difficulties overcoming economic hardship, social hardship, parents that haven't been to college is a good example of something that we can consider. And if people are faced with other sorts of bias in their lives, disabilities, race, those can be considered. But how we tell that story is very tricky. We're actually not happy with where we are in terms of underrepresented minorities, but we're still twice the average of a US medical school. And so we're going to continue to work on pipeline, and we're going to continue to work on our processes in a goal to match the community that we serve. Oh, we lost you.
Dr. Bell, we can't hear you. You're on mute. Well, thank you so much. Appreciate it.
You bet. I think Manager Jones had a question. I saw his hand up before.
Correct.
Okay, now you. Yeah.
Just a couple of comments. One is, I'd like to join the others in thanking for your leadership and support for the community here in Austin.
We can just barely hear you.
Bear with us as we deal with some technical issues on this side. This is our first hybrid meeting, and so we're trying to get it so that people can hear us and we can hear you the best we can.
Can you hear me okay better now?
Yes.
I was just saying that, first of all, I'd like to thank you for your leadership, your inauguration as the first dean here and the work you've done. We truly appreciate it. I'd like to acknowledge that. Second item is, I'd like to talk about in terms of service delivery by students. I don't know if you have any data or if UT has any data of the prevalence of students in zip codes in what we call the Eastern Crescent of actual service in those locations. I don't know if you would have that, if community care would have that, mental health would have that. I think it would be helpful because a unit, to the degree we can develop a unit of cost of investment, 35 million of their students, faculty, and others in our community goes a long way to justifying the ongoing support or not of the efforts that we have here, because I think that's an important question. One, I don't know if you have that, or if you can direct us to where we might be able to do that.
Yeah, that's a great question. No, we don't have that. You know, the students are working in the same facilities that the residents are working. So you saw that the residents are working in facilities that are, you know, critical to the safety net, 5/7 of their effort. We don't have it by zip code. We have it by payer. I wonder if we could get it by zip code. It's a very interesting question. I'll tell you, most of the medical students' work, most of their learning occurs in an inpatient setting. And then their outpatient experiences are spread throughout the city, mostly in areas of greatest need, not in, you know, something on the west side of town. But I can't give you more detail than that. But we'll go back and look.
And I appreciate that because and I know you may not be able to, or the university may not be able to, but I do think manager, CEO, Houston, we need to look at that unit cost of investment by students, faculty in our area. But what I hear a lot is, I don't see them. I don't understand where they're doing. Whereas what Dr. Johnston is saying, I understand and I see, I try and share that. In other communities in Texas, I know we use it, or new, but that prevalence, that presence, was well defined and well understood and connected. And people saw university medical centers in the communities that they saw. And I'm just saying, I think it'd be helpful that visibility goes to be made prevalent, and we could one justify it and help people to understand where that is occurring.
Yeah.
Comes to mind, for example, how many students, I don't need to answer now, but how many students were actually out getting or participating in the vaccination efforts that we did in the community. So we can say 35 million is invested, and of that, we had, 500, 600 students were actually out in the field doing that in the Eastern Crescent or wherever. So I just think that level of specificity. You know, I'm not suggesting you need to get a doctor, Dean Johnson, but I think that would be helpful to get us to get to the university. And my last comment is, as new models of healthcare and providers of healthcare occur in the city and in the county, and UT is a vital part of our healthcare system, there is the flexibility of contracting with or collaborating with models of providers of care in the community, separate and apart from maybe central health. And once again, I don't know if that's a question you can answer now, but it may be something you may want to share with your successor and others in terms of other partners you may join in with as well.
So do you mean having that kind of care how is it contracted with others in need outside of the central health target population?
So those in targeted populations, but other providers of care. So we know the CTIN, but there are other providers of care that we're collaborating with, or new ones that may come in. What is that opportunity, if any, for us to be able to do that?
I understand. That's a very good question. I can't answer that today, but I know that there are other players, and it's important for you all to have options to be able to meet the needs of the community.
Thanks very much, I appreciate it.
Karen?
Chair Greenberg, please.
Yes, thank you. Thank you, Clay, for your tremendous service to our community. We really appreciate it. And I also want to extend our thanks to you and to all of the staff for the tireless work you've been doing during COVID-19 and the modeling and data and things you have been providing. I think there were some excellent questions asked here. I know Manager Valadez submitted some, and Manager Jones had some, and I look forward to your responses to that and to your successors' ability to meet with us. Thank you so much. Deeply appreciate you and all that you've done.
Thank you.
Chair Greenberg.
Yep, we'll get those answers to you all.
Thank you, Dr. Johnston. We really appreciate all of the information you provided, and good luck with whatever the endeavors you choose. And I hope you stay in touch.
Thank you, I will. We'll be here in Austin, and I'm still on this journey with you all to figure out how we transform the health system. So thank you all for all the work we've been able to do together. It's been a real joy.
Thank you. All right, we are right on time for that agenda item. So I would like to bring up agenda item number 3, introduce and receive a presentation from Central Health Enterprise Chief Medical Officer, including updates on clinical leadership structures that support systems-based planning for healthcare and a clinical diversity initiative. And I have Dr. Alan Shawsha and John Morgan presenting.
Good afternoon. Thank you, Dr. Bell. Just a quick sound check. Make sure you can hear me okay.
Yes, we can hear
Excellent.
you.
Great. Thank you all for your time this afternoon. We're very excited to provide a few updates for you today regarding Central Health's practice of medicine and our process, the work that we've been going through to establish our medical executive board and the other related direct practice infrastructure. This is an informational only item today, requires no action from the committee this afternoon. I'm also excited and have the pleasure to formally introduce you all to Dr. Alan Shawsha. Alan's now a familiar face to most, if not all of you. Dr. Shawsha started with us full-time back in July and previously served as our interim chief medical officer, as you all are aware, while he was still holding the full-time job of CMO at Community Care. So we're grateful to him and Community Care for loaning us his time over that time period. We're excited to have Alan here at Central Health, not only to lead the building of our clinical practice and governing clinical care for our patients across our network of contracted providers, but also to continue aligning our work with Community Care, with the medical school, Ascension Seton, and many other clinical partners in the community who Dr. Shawsha already has established relationships with. Dr. Shawsha is a board certified family medicine physician and a doctor of osteopathic medicine for his training. And prior to serving as the CMO at Community Care since 2016, he also served as the chief medical officer at Honor Health, which is an FQHC system in Arizona. Alan Also holds a faculty appointment in the Department of Population Health at the medical school, and has served in various leadership roles in the family medicine division at the school. He has a long list of awards and recognitions that I won't read off, but suffice it to say they're from multiple community, clinical, and academic organizations. I will just point out one recent one, a local recognition that in 2019, Dr. Shawsha was recognized as the Humanitarian of the Year by the Travis County Medical Society here locally. And finally, I'd like to acknowledge Dr. Shawsha's work for many years, I think in excess of 10 years, leading international medical outreach missions in Guatemala and serving in organizational leadership roles for the sponsoring organization, Doc Care International. Alan will be joining me today in this presentation. I want to acknowledge that he's been here now 6 or 7 weeks on the job full time, but he is diving in very quickly and helping us move the important work of Central Health forward. I'm going to provide a little bit of historical context, and then I'll turn over the final part of the presentation to Dr. Shawsha. But certainly want to welcome him today and make sure we're taking the time to introduce him to the committee. Brianna, would you go to the next slide, please? So as a reminder, this is a bit of history. In not the most recent legislation, but the most recent legislative session, but in the one that preceded it and concluded 2 years ago, our team here at Central Health pursued a change to Central Health's enabling legislation to allow us to employ physicians directly, in addition to what we do at Community Care and Sendero, and also to directly practice medicine here at Central Health. As is customary with these types of employed physician models, the legislation required Central Health to establish a medical executive board with the purpose of ensuring the independent practice of medicine of our employed physicians. Can you hit the next slide, please? After that legislation was passed, the Central Health Board at the time adopted a resolution. Many of you will remember that. You all directed us as staff to take the necessary steps to establish the Medical Executive Board in line with the requirements of the statute and applicable regulations. This slide demonstrates that the Central Health Board established the MEB by resolution to oversee Central Health's practice of medicine on behalf of the district. And on the right-hand side of this slide, you can see the basic structure of that MEB as we described it at that time. Conceptually, this body oversees both our direct practice of medicine for our employed physicians, but as I've mentioned, it also governs care for our patients in our network of contracted services. Now, clearly today, the contracted services side heavily outweighs the direct practice side, but the direct practice side of our work is growing and building rapidly with the creation of the MEB, the hiring of our chief medical officer, and the service delivery initiatives that you all have heard quite a bit about that are built into our FY22 budget. Next slide, please. This slide is intended to provide an update to the committee today on some of our major milestones over the past 18 months, as well as a few of our next steps. As you can see, following the board's direction, we established the MEB itself in February of 2020, and the committees that are required by statute at a minimum. And we've developed the bylaws and policies for each of those bodies. I'm pleased to share that all of our required committees and policies have been developed and adopted, and these committees are now meeting routinely. I really can't overemphasize the amount of effort from our team over the past 18 months to really get us where we are today. Developing and operating this structure is pretty complex, and it's critically important to our service delivery work moving forward. Finally, there are a few next steps for our work that I'd like to highlight before turning this over to Alan. In order to directly practice medicine, there are a few more pieces that we're working on in addition to the Medical Executive Board. We're in the final steps of obtaining a professional malpractice policy that will cover our employed physicians and our practice. We're developing patient intake forms and registration forms, patient education materials A lot of this is around the surgical podiatry work that you all have heard a lot about to start with, but a lot of those forms will also be used in other practice areas moving forward. We're also going through the process to obtain a national provider identification number and a Texas provider identification number. These are the steps that we need to take in order to enroll with Medicare and Medicaid if and when that time comes. It's also a requirement for participation in other programs. We do still have to develop a conflict resolution process. That's in the works, and that's to help resolve any conflicts that may arise between policies set and adopted by the MEB and those set by the board for Central Health itself. So we'll be bringing that back to you all in the near future. The medical record keeping, having an electronic health record is important for a lot of different reasons. We really wanted to start and prioritize, as you all are aware, the community care Epic implementation. We're happy to see that go live has taken place earlier this year, and now we're starting to look at what an Epic implementation might look like for Central Health to support this direct practice of medicine. I'm going to turn the presentation over to Alan, who's going to talk a little bit more about the clinical practice planning and development, as well as the continued identification and recruitment of MEB committee members and clinical subject matter expertise for participation on the medical executive board, as well as leading our clinical services development. Alan?
Thank you. Good afternoon, Board of Managers. Can everybody hear me okay? Can I get a thumbs up? Okay, thank you. If we could go to the next slide, please. Okay. First, I want to, John, thank you for that very humbling introduction. And I hope that over the course of my tenure here, I can live up to that. I can tell you that today's presentation speaks to the reason that I joined Central Health. And I think our cogwheel slide is a perfect explanation of that. In front of you is a demonstration of kind of components of a high functioning system. And the motivation for me to join this amazing team was to help really fill in the gaps where our patients were falling out of care, where there were opportunities to improve care. So the aim of my presentation today is to review concentrated work efforts that will be engaged in from our team over the next fiscal year that John alluded to. And the reason that I'm going to cover those is because it speaks specifically to the positions that we're first going to be bringing onto the medical executive board, right? All of these concentrated areas are areas that you have heard before, and so I'm going to very briefly run through some of them. Under your strategic direction and utilizing a systems-based approach, looking at data, specifically mortality and morbidity, patient experience, bringing in subject matter experts as is appropriate, looking at health disparities, and looking at the cascading effects that our initiatives would have downstream. We concentrated on we will be concentrating on 6 additional work areas in this next year. Those areas are increasing specialty access, working on different initiatives for healthcare for the homeless, behavioral health, and I'll touch on that, substance use disorders, transitions of care, clinical and patient education. Now, some of the initiatives that I'm going to speak to will fit very cleanly in one of the cogs, and then others will really transition, throughout the system. If we could have the first animation, please. We all know that we need to improve access to specialty care. This year, we will be concentrating on providing ambulatory dialysis to our patients. We've spoken previously about the tragic occurrences of our patients going to the ED to receive what's known as compassionate dialysis. And as we move forward, we really need to have predictable outpatient access for our patients so that they can really operate more full and happy and functional lives. We'll be increasing and improving our access to e-consults. We'll be increasing specialty access to cardiology, nephrology, endocrinology, neurology, and rheumatology, and there are more to come. As everybody is aware, we have ambulatory podiatry in place. And our teams have been working hard really to connect the ambulatory setting to the inpatient or to ambulatory surgery centers so that we can truly have fluid transitions of care for our patients who need more in-depth surgical procedures. And so those are scheduled, or those initiatives are scheduled for this year. We've also spoken to the fact that we need additional infectious disease initiatives. Some of our patients transition from an inpatient environment to an outpatient environment, and we need to ensure that if they're on IV-based care methodologies, that they don't fall out of care and that they have access to kind of to answer their questions or to help govern their medication regimes. Next animation, please. We've spoken to our intensive outpatient clinics, and when I talk about intensive outpatient clinics, I'm really speaking to our clinics that care for people with a diagnosis of HIV, for our environments where we care for people experiencing homelessness, for our chronic renal disease patients. CareCo is an example of a clinic that cares for many of our intensive outpatient care needs. We will be expanding our healthcare for the homeless teams for that entire wraparound care. We're also working with partners to get what we hope to be 2 vehicles, which will provide greater privacy for our patients. We shared with you all that we have already, I think, made an offer to a community health worker who will be working in one of our communities, partnered with a nutritionist and a nephrologist to provide culturally appropriate care and education that will be bi-directional. So from the communities we serve to the nutritionist and to the nephrologist, and then education from our clinical providers and educators to the communities where these patients have some of the more advanced diseases. We're going to start with advanced kidney disease and then move on to heart failure and other disease processes. We've spoken to the fact that we really need to increase access for substance use disorders. And Dr. John Weems and Josh presented those initiatives to you. We will be concentrating on that. Next slide, please. We need to expand both as related to our social workers and to psychiatric access, both in an ambulatory care setting and for some of our patients that experience homelessness. We need to provide immediate access for some of our high-risk populations and just expand across the board as related to mental health. Next animation, please. There will be additional clinics coming on board. We look not only to increase access to care by those clinics becoming active, but also looking at hours and same-day access, as the board has voiced, is imperative to improve patient care. We're looking at medical weight loss. In the past, there was behavioral health modification for weight loss, and there was surgical access for weight loss. And there are relatively new medications out that have shown to be just as effective as some of our surgical processes as far as improving morbidity and mortality for our patients. And so we will be concentrating on those initiatives. During the pandemic, we've come to realize that we need to be open to utilizing multiple methodologies to create access for our patients to care, whether it's an in-home monitoring methodology or whether it is telehealth or telephonic care. And so we will be concentrating on increasing methodologies to access care. Next animation, please. Post-acute, respite, SNF, hospice will be increasing access to all of those environments. Next animation, please. And transitions of care. This is our central cog. And as we've said before, our transitions of care are the most important aspect in ensuring that patients flow smoothly from one clinical environment to the next clinical environment. You all have already supported the fact or the increase of our case management and care coordination team that is moving additional patient care. We are looking to bring on peer recovery specialists. One of the initiatives that we were made aware of that really needed to be focused on is as patients transition from an in-hospital setting where if they may have an alcohol use disorder to an outpatient setting, many of the patients stand the risk of falling out of care as they make that transition. And so we'll be bringing on personnel to help patients transition. We'll also be looking at bringing on other clinical personnel to help with the transitions of inpatient to ambulatory settings. Even for our patients that are seen in the hospital and then follow up in our primary care clinics, we have significant opportunities in ensuring that their care does not fall. And so we need to wrap their care in hospital to ensure that our ambulatory providers get, as I said before, that wrapped case summation. If we can have the next slide, please. And so this is our medical executive board, right? Now the medical executive board will hopefully go through many phases. This is our beginning phase, right? All of the chairs of the individuals that are represented here don't necessarily represent a one FTE. Because our practice of medicine will start out slow and we will increase that practice as is appropriate, so the FTE allocation of the people that we bring on board will be sized accordingly. The reason we have individuals in seats is we've often spoken about the need to have a seat at the table when processes, policies, initiatives are being discussed as related to patient care within our governance area. And so by bringing subject matter experts in-house, we hope to have a seat at the table to help prep and develop initiatives before they actually make it to the endpoint where we have to adopt it. I do want to thank our graphic designers because they give the chief medical officer in this graphic hair, and so I'll take hair any way, shape, or form I can get it. The positions that we have on board today is we actually have myself and Dr. Brown. Dr. Brown is our utilization expert, and this is really looking at efficiencies of care or the opportunity to increase efficiencies of care. We're both 1.0 FTEs. Now, the majority of these positions will be physicians. There is an opportunity to potentially have non-physician, non-voting members on the medical executive board, and this would be done solely to increase access for expertise. We have podiatry labeled on our medical executive board. This was placed on here before Dr. Peel's passing. Our thought was to have Dr. Peel sit on the medical executive board because of his expertise in surgery, because of his expertise in transitions of care, and because of his mission alignment. Tragically, that's not going to occur due to his passing, but we are still considering whether podiatry is appropriate. Another environment where we may have a non-physician on the medical executive board is pharmacy. In many of our discussions, pharmacy and pharmaceuticals will come into play, and so having somebody who governs that expertise sit amongst the other medical directors and share his or her expertise is critically important. One of the first medical directors or medical executive board members that we look to bring on board is our health equity and quality director. We look at data, we look at demographics, and we are made aware of inequities that exist within our system. We've been doing this a while and we have lots of opportunity to improve. As we move forward, we need to continue to look through the lens of health equity as we develop program. And so having somebody sit at our medical executive table in development of processes and procedures is critically important. Informatics and quality. Informatics and quality as we roll out and as we practice medicine, so we need to be able to, in real time, look at the care that is actually being conducted and react to that quality. and therefore this is critical to our practice of medicine. Technology and care integration. John spoke to the board support of EPIC within the CUC environment. As we practice medicine, we need an electronic health record system in order to chart off of and to communicate with our partners. Having a clinician who understands the technological basis of a system and the clinical aspects of a system, with he or she having one foot in the space with our joint tech colleagues and one foot in this clinical space, will really increase, the opportunity for us to successfully transition to a functional electronic health record. Post-acute. We are all aware of the importance of transitions from an in-hospital setting to a skilled nurse facility or to rehab. This medical director, we expect to be practicing medicine in the environment in which he or she has expertise, but we really need somebody that serves as a champion for our patients that are making those transitions. Healthcare for the homeless, Dr. Kwong and Josh presented to you all previously. There are so many discussions that are occurring in and around Austin as related to people experiencing homelessness. We really do need a seat at the table. We need to partner with the many organizations that are advocating for these patients. And we need to work on how we are going to continue to administer care to the patients that are living in the street, and how we can increase access to respite, because there is still not enough access, and our patients are either being readmitted or staying in skilled nursing facilities just because we don't have the appropriate access. Both by way of Dr. John Weems and Dr. John Swanson, we spoke to the critical need to increase access for mental health diagnoses and for substance use disorders. There's a critical need that we're not meeting, and governing that expertise within our clinical environment is going to be critical to how we set up our next steps and how we best prepare our infrastructure for our patients and their need. Again, this is not a 1.0 for every individual. For some of these medical directors, they may have a one-day allocation to our medical executive board, and we will grow as is appropriate. I did want to say this is a very exciting presentation to be able to give. This is a part of our systems of care. The presentation that you will receive following this one as related to Guidehouse is yet the next step. It is a systematic approach to how we are working with our partners and looking at the communities that we so humbly serve, and take that very calculated, evidence-based step in moving care forward. So really looking forward to Guidehouse's presentation. I'll stop there. Thank you very much. And John and I can take questions if that's appropriate.
Thank you very much, Dr. Shawsha. I really appreciate the fact of how you try to depict diversity in our medical executive board. It also reflects to me that medicine is no longer about just a physician. It is about all of the activities that are associated in taking care of an individual with a condition. And to have all that represented on the board, to me, is exciting. And it moves us forward in a way of practicing medicine that you don't see very often. So I think, go ahead, Dr. Shawsha.
Oh, I just said thank you.
Yeah, I really appreciate that, and I appreciate that model. Let's see, I've got Manager Musaitis and Manager Valadez. So Manager Musaitis, you want to go first?
Sure, thank you. Thank you, Dr. Shelson. Welcome on board. We're really happy to have you. By the way, I was really happy when I saw that tweet about honoring you. I'm like, hey, he's our new medical director. My question relates to your last slide. If you can pull it up. I actually feel that there needs to be a public health person that is missing from your board. I know we are, as a whole, we're advocating for bridging public health with healthcare, and we want to address the health disparities, which is the inequalities of health. But that voice is missing from the table that is critical to assess the needs, that can really oversee the overarching work that you are doing from a systems and a public health perspective. I know there are components of it, but it doesn't have a seat at the table. I hope and that that person will have, that division field will have a voice at the table. So as we are approaching this, addressing health, not just healthcare. Overall, thank you.
Okay, thank you. Thank you so much for sharing that perspective, and very interesting food for thought. We will definitely consider that and follow up with you. Thanks so much.
Dr. Bell, if I may.
Yes, Mike?
Yes, Manager Musada, this is Mike. In response to your question, the next set of slides that you'll see speaks to the level of coordination and strategy development, which does have public health at the table. So we can speak to that in some degree on the next set of slides. This one's specifically focused on the filling the statutory mission of the medical executive board, but we do speak to the issue.
I understand. Thank you.
Thank you very much. I'll go to Manager Valadez and then Manager Jones. Manager Valadez, unmute, please.
Thank you very much, Dr. Bell. Thank you, Alan, for this presentation. We know we appreciate you here, but I'm going to tell you where I'm coming from. As I sit on the Central Health Board, as a person who lives in this world, you're missing a person who lives in that world. We can tell you as family members in living there, or someone who may have an addictive disorder, or someone who is trying to manage and navigate the various systems and appointments and resources and everything else. You need a person who is living in that world, who can tell you, the doctors sitting at the table, the experts sitting at the table, well, you all may think it's working, but this is what I'm really seeing. I think that's important. Even if you don't understand always, because you don't live in that world, you may have doctors, unless you do have doctors who have been there, survive that, and move forward and are advocating in this position, in their positions as providers. You will not get that perspective. That perspective, that lens, as you're talking to address everything at the same time, the medical, the pharmaceutical, the transition of care, the inequities, the blah, 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 et cetera. You go down the line, and unless you have that person at your table telling you, and I'm not talking about a public health or community advocate. No, I'm talking about a real person who lives in that world, okay? Because they do know and can tell you where they may see the gaps that you all may not realize gaps exist. So I would appreciate you understanding and internalizing that, and maybe leaving a space open for that kind of a person, because that profile and looking at the patients and population that you serve is going to be a very important one if you get the right person who can communicate all those things. Thank you.
Thank you for the
Thanks,
input, Manager Valadez.
Excellent input. Thank you. Manager Jones?
Thanks very much. A very good presentation. Could you go back to slide 3, I think?
Slide 3?
Yes. Yes, I agree with both what, first of all, I think it's a great presentation. I appreciate it. But just a few caveats. When I agree with what Manager Massakin said, particularly in public health, I think that'd be important to incorporate in terms of this model somewhat. Second, I also agree with Manager Valdez because I do think that the homegrown experience in terms of dealing with these systems and understanding them will help you be able to make strategies and policies and practice implementation. So I'll say that. But my question more goes to this dotted line that runs with Central Health Board of Managers, the Central Health Medical Executive Board. I guess my question, I know we've had discussions before, but I want to make sure I'm clear on what that really represents. So is this a board, is this a board that will oversee the medical component? I get that. Do they report back to the Central Health Board? Do they have independent operations and authorities? How actually does that fit in line with our responsibility? And who's ultimately responsible for final decisions on questions that will come up that are both policy and medical practice?
Dr. Shawsha or Mike? John?
Thanks. Yeah.
Dr. Bell, if I could maybe take first stab at that, Manager Jones, great question. So going back to I think the slide before this, so the legislature and the statute that was changed requires the creation of a medical executive board for the sole purpose of ensuring independent medical practice by our employed physicians. And I want to take a step back because I think this maybe addresses some of the two prior questions as well, that this body is not where we will conduct the majority of our clinical services planning and developing our future practice. This is to oversee the actual clinical practice of medicine. So when we're talking about MEB members or medical directors, we're talking about physicians, and we're talking about central health employees, people that are central health overseeing central health's practice of medicine. I want to go back to Mike's comment that the subsequent presentation from Guidehouse, I think, will speak a lot to community engagement, to patient engagement, and to our overall strategic planning process for clinical services. This is a much more narrow focus. But if you go back to slide 3, Brianna, there is a reporting relationship here between the Medical Executive Board to the Central Health Board of Managers. This is one early example of that type of reporting, and we will have other reporting and more frequent reporting now that this structure is stood up. For example, we'll bring credentialing updates periodically to the Central Health Board so that you're aware of the actions that are being taken by the MEB in terms of credentialing providers to either practice on behalf of Central Health here in our clinical structure or through our network of contracted providers. There will be conflicts, certainly, and that is the piece that I mentioned earlier that is still under development, is that conflict resolution process where there's maybe it's a budget decision that's made by the Central Health Board that conflicts with a recommendation or a decision made by the MEB that is a clinical practice decision. And that conflict resolution process is still under development, but we expect to have that complete here in the next few months and brought back to the board for discussion and approval of that process. So hearing those types of conflicts and developing a resolution process is part of what will take place there. I'm happy to answer subsequent questions, Manager Jones.
Yeah, I just want to end it with a real life scenario. The governor signed yesterday this abortion bill, and to the degree that we in Central Health or this medical board could be identified as one who, under the definition as I understand it, helps refer provides information, support to those who may, or fund even those programs, question, where does that liability lie? And I know you may not be able to answer that specifically, but that's just an example of, is that a central health or is that a medical board, since that's a medical practice?
I think that's a great example, Manager Jones. I don't think we're prepared to really respond in too much detail to that specific scenario today, but I think it is a really good example.
John, if I may, those specific questions about liability, that's the sort of thing that the medical executive board and this board would want to have consultation with legal counsel under Prevalence. As it relates to the practice of medicine, I mean, generally the way I tend to get my mind wrapped around this is that the central health board enables the medical executive. And, you know, to the extent that the medical executive board can't do something by virtue of the bylaws or the statute, the way it's configured, that's going to then come back to the central health board to actually execute on the governance decision as opposed to the practice of medicine decision. So that may not be as clear cut, but it's, you know, kind of my functional working definition that I use day in, day out to understand the relationship.
I don't want to belabor it, and I hear what you're saying, but to validate this question, there will be nuances where what communities want or individuals need, the
Right.
board may agree with, but the medical executive board may say, oh, no, we're not supportive of that for these medical reasons, and how do we resolve that kind of situation?
Yes, sir, and actually, when we get into the next presentation, Dr. Bell, when we get there, if you'll permit us to come back to these questions that you've asked and what Manager Valdez brought up, I think we can help clarify some of these gaps, but they're excellent points to bring up and need to be discussed. I'm glad you all are doing this. Thank you.
Thank you both. Manager Recycling?
Yes, thank you. I have a quick question related to what Manager Jones asked. Now, is there going to be any representation at from Central Health Board to this medical executive board? And are these open meetings that we have access or the public has access to listen into in terms of, you know, decision making? And I think we are in a critical position that we are founded by the, you know, we're adhering to the community needs, and we need to know what the decision making that's happening at this executive medical executive board. So I'm just, in terms of hierarchy, how is this played? Are like, we're the board of managers, this is underneath us, or are we in parallel? Like, is there any representation of us there? How frequent are we going to hear? So from this board, so it's not clear from my end. You may have discussed it at a prior meeting. So if you can just elaborate on that in terms of communication and who sits, is there a representative? Like, you know, how Sendero we have, Dr. Bell is the chair. Is there a representative of a Central Health board member on this medical executive board that they can be our liaison?
Thank you, Manager Recycling. I'll need a quick answer to that because we are running quickly out of time on this item. If we don't have one, then we can bring that up at a future meeting and have that further discussion. Mike?
Yes, what I would recommend, unless John or Monica, if you have a quick answer, great. If not, then we'll need to bring that up at the time that we start to do more work on the medical executive board in terms of actual board membership and how there's a crossover or potential crossover with Central Health board membership.
Okay, thank you very much. Thank you, members. I'd like to now bring up agenda item number 4, receive an update from Guidehouse Incorporated on their engagement to facilitate the development of an equity-focused service delivery strategic plan. Monica Crowley, Dr. Avi Sharma, and Katrina Keys will be presenting.
Thank you, and I am just going to hand this off to the Guidehouse team so that they can get rolling. We're very excited about this kickoff today, and This is related to the service delivery strategic planning work that we are entering phase 3 of, and this is the kickoff of our engagement with Guidehouse that you guys approved, I think, at our last meeting. Thank you so much, Dr. Sharma. And I can't hear Dr. Sharma. I don't know if he needs to be unmuted on the internal side.
I don't hear him either.
Dr. Sean, if you can hear us, we're not showing that you're muted, but if you will press *6.
Can you hear me now?
Yes, we can, thank you.
Oh, perfect, perfect. Sorry about that. And Monica, thank you for introducing the project as well as our team. So in the next 30 minutes, we wanted to do 3 things. The first one was to provide an overview of the strategic systems of care planning work that we have already kicked off. The second one is to provide an overview of the methodology of how we are going to go about it. And the third one was a list of deliverables or the outputs of that work. So we want to make sure that we, again, provide an overview of our engagement in the next 30 minutes. If you go to the next slide, it just gives some of the key topics that we wanted to go over. Can we go to the next slide, please? So I wanted to give a brief introduction of our team, and I'll start with our strategic advisors. So Dennis and Mike have been in consulting for over 20 years, and they are currently in leadership positions at Guidehouse. Both of them are partners, and they will be advising us on strategic initiatives and strategic analyses that we will be running on this project. The engagement team is comprised of 8 members. My name, as you can see here, is Alan Sharma. I'm a practicing MD. My specialty is ED medicine. I got my residency from Johns Hopkins. Immediately after that, started working for the Army. I was stationed in Iraq, Sierra Leone, Syria for about 4 years as a frontline medic. Came back to the US, got my MBA, and have been in consulting for over 10 years now. Most of the consulting work that I've been doing has been in strategy. The 2 projects that I think are relevant for me to call out are, number one, a project that I led with the University of Texas Brownsville, where we created system-wide strategies for them to provide accessible care to populations around the Brownsville, Texas border, Brownsville, Mexico border, as well as a recent engagement that I led with Harris County, where it was again focused on devising a go-forward strategy for the system to provide care and access to populations in need in the Harris County area. I'll pass it over to Danielle to give an introduction as well.
Hi, good afternoon, everybody. My name is Danielle Srinivasan, and I'm also a director in Guidehouse's strategic planning practice. So my areas of expertise and core focus is on strategy and community health needs planning and working with organizations such as yourself. So I've done this across the country and have worked in organizations similar to Central Health and started my career on the provider side, but now function on the advisory side. We are joined, as Abhi had mentioned, by an 8-person team, and that includes clinicians, strategists, market experts, and community and patient engagement experts. And what I'd like to do is just have Katrina Keys, who is from Case Strategies, introduce herself, because she will be leading that really critical work stream related to community engagement and the voice of the community.
Thank you, Danielle. This is Katrina Keys with Case Strategies, and we are a marketing and public relations agency here in Texas, and we will be working with the team for community engagement, also understanding patients, customers, and really getting into the nitty-gritty of everyone in the community, how they can have a voice, how we can understand their needs, and how we can communicate to make everything transparent and what we're doing and getting great data. So we're really looking forward to working with the team in Central Health. Thank you.
All right, next slide, please. So as you can see here, we are working with Katrina and her team from Case Strategies, as well as Broadus and Associates. And both of these organizations qualify as historically underutilized businesses under that program within the state of Texas. Broadus brings to us proprietary market data that is specific to your community and your service area that will really help us hone in on what are those community needs for some of our most vulnerable, underserved populations within Travis County. So we will be working closely with them as well to complete this engagement. Next slide, please. One more, please. This slide here is a follow-up to Dr. Shawsha's earlier presentation. And really what we want to do is build on his comments earlier, where we look at what are the components of a high-functioning system to really understand where are the gaps today in our existing system, and then how do we position ourselves to really address needs in the future? So what are those needs across our community? And then where are the needs for some of those most vulnerable populations? So when we think about access, equity, and the ability just to receive care and quality outcomes, there's a myriad of access points when services that are needed to really drive health in the district. Abby, is there anything that you'd like to add here?
Yeah, so as this slide elucidates, a high functioning system depends on a lot of gears working in cohesion with one another. And although this looks complicated, I think the key idea here is that we have to prioritize from within these gears in order to move access in the right direction. So one of the key outputs of our engagement is a list of prioritized gaps and needs that need to be addressed through moving the system in different directions.
Next slide, please. So when we think about the future direction of the system and what does it look like, there's a lot of work that is really involved in developing your services strategic plan. So really kind of creating that vision of the future. So what is that future look of your services delivery system? Creating buy-in and alignment around that vision, and then agreeing on what that future state is. So when we think about strategic planning, it's really thinking about what are the drivers where we can impact the future. And then the difference between strategy and operations is the execution and the action. So really breaking it down, assigning accountabilities, creating engagement and buy-in with our staff and our teams, and monitoring and measuring results. And as part of that exercise, there's also some financial components that we'll review on the next slide. So when we look at the service delivery strategic plan, it's really helping us drive our operational and financial sustainability planning to support our overall mission. So it's a 3 to 7 year outlook. It considers the changes in healthcare, gaps in our community, the voice of that community. So what are some of the factors that don't show up in the data that really drive the way that our community is able to access care. So going back to earlier comments in the prior presentation, what does it look like to live in this world today and to really access care? And then what are some of the forecasts or demand that we are seeing for care in the community that really helps to inform Central Health on what that future delivery system needs to look like? When we think about the operational or implementation plans, those are typically anywhere between annual plans to 3 years out, but that's really the execution of your strategy. So it's an action plan that is a paint by numbers approach that helps folks guide their work day to day so that we're working towards the same vision. And then our financial sustainability plan is really our long range financial planning. So what are the dollars that it's going to take to really achieve and realize this vision, and the capital considerations that we need to work through to get there? Okay, next slide, please. So going through this process, and as Abby had mentioned, there's 3 separate deliverables associated with this scope of work that we're going to review with you shortly. But as an outcome to this work, what we're really trying to do and what we will do is help you shape the future service delivery system for Central Health. So what that means is we're helping you understand where the pockets of needs are within the district, and then where we may need to overlay services. So when we think about facility planning, we like to say form follows function. So your facility design or new facilities should follow the strategy development of this phase of work. So when we look at the market and your needs, we'll help you identify where you need to place services based on those needs. It should support your overall strategy. So the facilities must have a relevant purpose. They must meet community need and really support that overall strategic plan in support of your service delivery system. It will be data-driven. So master planning looks at the forecast for the community and demand to make sure that we're sizing our services appropriately and we have the providers in place and are aligned with us to deliver on care. And that goes hand in hand with right sizing. Okay, next slide, please. One more, please. So when we think about the objectives of this scope of work, it's a tri-fold approach. And what we'll be doing for you is looking at the community needs for the district. So, and through that, developing a comprehensive community needs assessment report. So really understanding the current state of the safety net health system in Travis County, and then identifying where those gaps are and future needs. So the gaps and future needs will really help us formulate our future service delivery strategic plan. The voice of the community is really understanding that holistic perspective of patients, providers, and community members to really ensure that we're obtaining that hard to reach input from some of those populations so that our assessment is all inclusive. Katrina, did you want to add any comments to the voice of the community?
Yeah, that we definitely want to get information from all the different communities, you know, from our patients, providers, but also homeless communities, individuals where English may not be their first language. And while we're doing this engagement, we'll analyze that. So if we don't have enough participation, say in the homeless community, then we'll increase outreach in that area so we can get participation, because we want to make sure that we get information from all the diverse areas of the community, and that the data we get is not biased because it's only from a couple areas. So that's what we'll really be working for and looking at on this project, that we have diverse and inclusive participation.
Thank you, Katrina. And what we'll do is we'll really blend the findings or combine the findings between the community health needs assessment and voice of the community research to develop a well-rounded service delivery strategic plan that really guides the development of a high-functioning healthcare system for Central Health. Next slide, please. Okay. Abby, did you want to go through this slide?
Yep, sure. Thanks, Danielle. So in the next couple of slides, I want to walk us through our engagement approach, and we will dive into the specifics of some of these steps. And please feel free to stop me if you have questions. I'm happy to answer questions as they come up. So at a high level, our engagement has two built-in phases. The first phase will focus on assessing the current state, which is essentially doing two things. The first one is conducting a community health needs assessment and identifying the demand for services within the community. What goes alongside of that is an understanding of Central Health's capabilities. So when we say capabilities, we mean the ability of Central Health to provide services in a timely manner to the communities it's serving. As we conclude the first phase, we will compare needs with capabilities to identify where needs are not being met, and that would then translate into what we'll call gaps in care. Once we've identified those gaps, we will move over to phase two. In phase two, our primary focus will involve assessing those gaps, prioritizing those gaps, and then creating a multi-year roadmap for Central Health and its partners to close those gaps, and again, provide accessible care to quality services within Travis County. The thing that I want to highlight here is the importance of community engagement. In engagements of similar nature in the past, I've seen community engagement as being the core linchpin to the outcome that we want to generate out of a strategic plan. We want to make sure that we understand needs, not only from the data and systems perspective, but also from the community perspective, and then overlay those two to identify what best way to not only meet those needs is, but also what the best way to meet the expectations of the community would be for Central Health into the future. I want to move on to the next slide, but please feel free to ask questions as and when you have them. Now, at the center of our approach is the idea of health equity. And through our preliminary analysis, we've realized that the population in Central Health is dealing with a lot of health-related inequities. And if we go one level deeper, we know why some of those inequities are prevalent. So what we tried to do on this slide was to bucket the reasons for health inequity into these 5 high-level categories. So the first thing that we noticed was that there are a lot of social inequities. So across the community, poverty levels are high, proficiency with English is low, and there are also transportation and access-related issues. When we started to look at health insurance, there are a lot of patients who are uninsured. And then what makes that more complicated is that for some of these people, getting health insurance is not even an option. If you look at insurance coverage across the federally and state-funded programs. A large proportion of these patients are covered by Medicare, and a large proportion of them are also dependent on SNAP benefits in order to get coverage. The disease burden within the community is significantly high, and all of these factors that I talked about are exacerbating that burden even more. If we look at the prevalence of specific diseases, common diseases that are lifestyle associated, that are associated with limited access to healthcare, are amongst the top 4 or 5 within this community. If you look at geographic disparities, we know that there are certain areas that are certain areas where people are able to access healthcare, but then there are these pockets around Travis County where access to healthcare is not appropriate. And we want to make sure that we use these 5 ideas, again, overlay our findings from these with the voice of the community, and then come out with the strategy that we think Central Health should focus on in order to close these gaps and provide equitable healthcare to people in the region. If you go to the next slide, this slide, I think, is the core axiom that will inform our approach. So we wanted to bring it down to the basics. And what the core axiom here is that supply should follow demand. What that essentially means is the first thing for us to do is to identify where demand exists. Now, when we think about demand, it can be need for a particular service, need for a particular kind of clinician, or need for a particular location for access of the service. And then we think about supply is how we actually meet those needs. What kind of services should be provided? Where should those services be provided? And how or who should be providing those services? So the core idea of strategy and strategic planning is ensuring that we have a good understanding of demand, and then we create strategies that ensure that the supply is there to meet those demands in a very targeted and tailored fashion. Next slide, please. So we've kept talking about demand and need, but how do we go about assessing the magnitude of those needs? Now, we've laid out 2 examples here of how we will go about quantification of needs, which would then inform which need gets prioritized, and will also inform how we track the closure of those needs through the strategies that would come out of this engagement. The first set of needs that we want to account for are needs that are easily quantifiable. So in this instance, we use the example of encounters per 1,000 enrollees to quantify that need. Now, based on our preliminary analyses, we will find out what the current number of encounters per 1,000 enrollees in a particular community or cohort is. What we'll do then is we'll try to compare that number with what the need in a cohort that is similar in demographic to the original cohort, but is at the higher end of access is, and identify the gap between those 2. So in this instance, what we think the target cohort should be would be people who have commercial health insurance but are living in the same community. And by doing this analysis across those 2 cohorts, we will be able to identify the need and then use that to inform strategies as we look into the future. I know this is a very technical concept, so I want to take a pause here to take questions before I move on to the next slide.
Dr. Sharma, what I'd like to do is have you just go ahead and finish your presentation. We're a little bit on a time limit here because we will lose a. So if you just continue on, and I will sort of talk about how we're going to address questions. Okay?
Perfect. Sure. That works.
Thank you so much.
Absolutely. The next slide actually talks about some of the examples of data points that we will use to identify needs across different sites of care or provider types. So for specialists, we will use procedure wait times. So how long does it take for a patient to get access to a procedure? For hospitals, we'll use number of admissions by DRGs. So if an individual is diagnosed with a particular primary diagnosis, what time does it take for that person to be admitted? And then for a cohort of similar diagnoses, what's the percentage of admissions that are being made in a timely manner? For post-acute care, we'll use the same idea, but we will again use admissions as the core driver of needs assessment. And for primary care encounters, as I alluded to on the previous slide, we will use encounters as that core driver of needs assessment as we walk through our analyses. Next slide, please. So as all of us know, needs are not static, right? So using the criteria and the variables that we talked about, we will get a current state view of what those needs are. But we also need to be mindful about how those needs would change into the future. Strategy has to be forward-looking. And in order to do that, we will use certain criteria to then translate those criteria into variables that impact needs into the future. So some of the things that we think are pertinent to our forecasting are in the green text box on the left. So population is going to grow. There will be changes around Medicaid, Medicare, as well as AC enrollment. The impact of the COVID pandemic is lingering and will stay on quite some time. And there will also be continuing changes around the availability of provider staff as well as support staff that are involved in care delivery. So all of these changes eventually translate to the analytic variables that would help us project needs into the future. So some of those variables would be change in utilization. As population grows, utilization is supposed to grow. Change in access. For more people, if you don't improve capacity, access is going to be limited. Insurance coverage. If people get access to insurance, utilization sees an uptick. So how do we account for that into the future? And change in staffing needs. As the case mix, the mix of disease states within the community changes, staffing needs will have to keep up to match with those needs. So think about number of folks who would be accessing care, and then think about the providers that would be required to meet those needs. If you go one level deeper, the specialty of those providers would have to change in order to meet the changing needs of the population as time progresses and as more patients enter into the system. Next slide, please.
Okay, I mean, I can take this slide for our community engagement. So the voice of the community is so crucial to understanding the factors that influence patient access, connectedness, trust, and just improving healthcare equity among all, but definitely among our most valuable populations. So this slide kind of shows you kind of our process for community engagement, where we first will start off with how we want to define or have defined success indicators in terms of participation in throughout the area or location of zip codes, demographics, also understanding perceptions of the hospital. I think somebody may need to put on mute. Number of participants through the different engagement activities we want to conduct. So we'll first look at that and understand the indicators we want to have for success. Then we want to evaluate the current state. So what's the current perception? What are past outreach engagement activities you have done with the community? Also understanding where there have been barriers or challenges, so we can put together some strategies to overcome those in the beginning of the process. Then looking at how we conduct stakeholder mapping and identifying essential stakeholders, and that we understand all the diverse stakeholders and where they are and how they utilize or don't utilize services now. Also prioritizing based on level of interest and influence, and then having some key KPIs that will help us measure the success of the engagement at the end. and then just developing the engagement plan and also having the engagement activities. So first, having tailored communication materials, and that in the materials and messaging that we have, that there's diversity in that. When we send out materials, we want people to see themselves, because then they will engage and participate more if they see themselves in the materials, inviting them to a meeting or to participate in a survey. We also want to have diverse speakers, so that way they feel comfortable too in giving feedback and sharing how they feel, and looking at how we utilize virtual and in-person participation, especially through the pandemic right now, and just conducting, for in terms of engagement activities, conducting our focus groups, working sessions, community conversations, listening activities, surveys, and like I said, how we do that digitally, online, but also in-person activities so we get the maximum participation. And then just measuring success. We want to have measurable data and analytics to show high level of success matrix for our participation. So there's meaningful participation from diverse populations, that we have outreach to overcome barriers to get the maximum participation that we can attain, and then that we're exceeding the KPIs set for community engagement, and that we have a thorough understanding of the voice, the diverse voice and needs of healthcare needs in the community. And then last, that we have strategic imperatives and activities so you all can increase engagement of diverse populations for the future, not just during this engagement. So we really want to make sure for our goal for community engagement that we reach all the different groups and that we have good representation, so that the data information we have, we know really shows how people are currently activated in your services, and how we can increase and maximize those activations in the future. We can go to our next slide. Thank you.
Thanks, Katrina. So by the end of the first phase, based on the needs assessment, the current state assessment, as well as our assessment of the community needs through community engagement, we will have a very good understanding of what the needs are, and based on that, what some of the gaps are that are required to be filled to close to address the needs. Once we get to that point, the next step is prioritization of those gaps and needs. What we want to do during this step is to take the list of our needs and gaps and prioritize them based on 2 criteria. Now, what you see on the screen is not exhaustive, it's just illustrative for us to get the idea across. But the 2 criteria that we want to use is, first and foremost, impact on communities. And then the second one would be level of. If there is an area that has a very high impact on the community, we would go after those areas first. If there are areas that are not as impactful to the community, but are still easy for us to close, we are going to go after them as well. At the end of the prioritization phase, we would have a very good list of needs that need to be addressed. And underneath that, we would have the sequence in which the needs should be. What that would then dovetail into would be a full-fledged strategic roadmap that would talk about how those needs should eventually be addressed. We also wanted to highlight the fact that we will be running special analyses for special cohorts, so justice involved and the homeless. And we also want to make sure that when we think about the eventual prioritization, we also take community perception into account, because you operate in the community and addressing community needs is extremely important. And what goes with it is maintaining right community perceptions and gaining goodwill in the community. So when we think about prioritization, addressing those needs around community perception will be a core tenet we will use during the prioritization process. That was the last slide we had, and we can open it up for questions.
Thank you very much, Dr. Sharma. I appreciate that. And thank you all. That was an excellent presentation. Members, that was a lot of information to unpack in a very short period of time. And so I have talk or text with Monica, and we're going to strategically work to bring Guidehouse back to our meeting in October. We will have them summarize some of their concepts as well as additional activities that they've performed. And then what we will do is have about a 30 or 40 minute period that we can ask our questions. You can look at the models a little bit more in detail because now you have them and you also understand them a little better with their presentation, and can come back with some specific questions and maybe concerns that you want to voice to Guidehouse, and they can address those at that time. So if that's okay with all the members, I will move on to an adjournment, or to agenda item number 5, to confirm the next strategic planning committee meeting date, time, and location. Managers, our next Central Health Strategic Planning Committee meeting is tentatively scheduled for Wednesday, October 13th, 2021 at 1 p.m. at the Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702. At this time, I'm ready to accept a motion for adjournment. Chair Greenberg, I recognize you.
Thank you. I move adjournment.
I have a motion from Chair Greenberg. I have a second from Shannon Jones. All in favor?
Aye.
Hello.
Any?
Hello.
Did you have a second or what, Manager?
No, I was going to be a second, but I just wanted to make sure, Dr. Bell, that we provided Central Health and Community Care provided the last community needs assessment and demographic information to them. I'm sure they have. I just want to make sure that it gets done. That's the only thing I wanted to say, but I seconded it.
Yeah, well, Shannon seconded it, but.
Well, I know I had my hand up and you didn't quite see me, but that's okay.
I'm sorry about that. All right, we are adjourned. Thank you very much.
Thank you, members.
Thank you.
Bye. Thank you.